Welcome back. Today we're going to study the physiology of the heart and try to put into effect some of the practical aspects of how this wonderful mechanical pump works. By way of review, remember now that we have this very small, very efficient pump pushing blood, a very viscous liquid, through some 50,000 miles of vessels, both gross and microscopic, and beating at a rate that is able to put out some 20 quarts per minute at rest and much more during exercise, which amounts to about 1.5 million gallons a year, year after year. During an average cycle, let's say with a cardiac rate of 60 beats per minute, the rest period is less than a second. You can increase this factor by factors of 5 or even 8 times as much under conditions of extreme stress, and the heart is up to the job. There's something called cardiac reserve, which is enormous. This is a ratio between the maximum cardiac output and the resting output. And this is the figure that I mentioned, some 5 to 8 times the volume that can be delivered over what's delivered normally. Now, before we get into the actual physiology itself, there needs to be just one more definition before we get started, and that's the difference between systole and diastole. And it's important to understand when we talk about those two words, we're talking about the ventricles. When the heart squeezes to make its pumping motion and pump blood out, during the active time of squeezing, the high pressure propelling of blood out the major vessels, whether it's the pulmonary or the aortic vessel, the active squeezing is called systole. That's the high pressure end. Diastole is the relaxation that occurs, not necessarily very efficient or powerful. And if we lose atrial contraction, which we can do in disease states, the efficiency of the heart is only dropped somewhere up to about 30%. So, for example, there is a disease called atrial fibrillation. Fibrillation means uncoordinated contractions of the muscle. Instead of the atrium giving a good, solid, coordinated pump, it may wiggle like a bag of worms and really not pump anything. There's something called ventricular fibrillation, which is not compatible with life. That's what we often call a cardiac arrest, and that's what's happening when you see them put the paddles on somebody and shock them. They're trying to convert that fibrillation, the worm-like motion, back into a real contraction. In atrial fibrillation, patients can live for years with it. No effective blood is being pumped. It's merely being passively drained into the ventricle, either by gravity and or some suction that's created as the ventricle expands. So this part of the cycle, whether it's the right or the left atrium, means that we get extra efficiency by having good contractions, but not necessarily. It starts up here in the sinoatrial node and propagates, meaning every millimeter along the way passes along in a coordinated way down the atrium and into ending up here at the atrioventricular node. This node then picks up the beat and moves it on through the atrioventricular bundle of His. His was a man who discovered this physiology and got his name stuck onto it. You're going to hear a lot of those eponyms during this course. And then everything divides pretty systematically and moves along the rest of the cardiac muscle to make it contract. Now, again, evolution has done an extraordinary thing. It's made a little roadblock here. Remember what's happening. If you look at the atrial contraction, the electricity has come down very fast, but it takes a few microseconds for the muscle to respond. The ventricles would really like to have all the blood in there that they can get before pumping out, and I'll explain why. And so it takes a little extra time for the response to make these atria contract and then to get the blood into the two ventricles. This roadblock right here at the AV bundle is the one that does it. It slows conduction just long enough so that the electricity is held up, just like a traffic jam on a highway, and these atria have the ability to empty themselves completely into the ventricles. The ventricles then go ahead, fill, and do their ventricular ejection. There are disease states in which these fibers get blocked. These are called bundle branch blocks. You have a right and left bundle here because they're bundle of nervous tissue, or myofibers of Purkinje is what they're actually called. Another physiologist who attached his name. And something that happens to the myocardium, for example, a heart attack, instead of striking the muscle out here, it might strike the muscle right here, and not only injure the muscle, but might injure the conduction fibers. And that patient would have what's called a bundle branch block. If the block is severe enough and the pacemaker is not getting down to the portions of the ventricle that they need to, what's going to happen is the ventricle 20 or 30 beats a minute, very slowly. Only reason it's going 60, 70, 80 beats a minute is that it's being whipped by the node. The atria, their inherent rhythmic rate is whipping the ventricles. So what happens to that patient? Well, the first thing that happens is the patient may faint. Patient who has complete heart block or partial heart block may slow the rate so far down that the brain isn't getting enough blood or oxygen. Patient might have episodes of fainting, might have episodes of just feeling faint or weak or short of breath. And would go to see the doctor, who would see that their heart rate is actually only about 20, 30, 40 beats per minute. Not enough to do the job. And we have now a rather simple cure for that called the pacemaker. Patients then have a wire placed in their heart attached to an electrical stimulator. And what happens is that is fed through usually either a vein in the arm or a vein in the leg. It's fed backwards up into the right atrium, to the vena cava, which is this big vessel, and down through here under fluoroscopy and wedged against the heart muscle. The pacemaker then sends little impulses at whatever rate we want and determine, and it does the same thing the node does. But now we're bypassing this block and pacing the heart down here. Now, when I first went into medical school, these pacemakers had a fixed rate, so we made them go about 70 or 80 beats per minute, which was adequate for most people, but they could not increase their rate if they had to. And battery life was also not very long, so these pacemakers had to be changed. Today we have demand pacemakers, which have computers in them that can sense the need for increased rate and can increase their rate. They might have somebody who has an intermittent block. And when the heart is beating normally, the pacemakers don't fire. But if there's a pause, the pacemaker will fire. They have variable rates, they have very long life batteries, and they can do very well over many, many years and save a lot of patients' lives and return them to normal activity. When the patient, going back to this diagram, didn't die of a heart attack from an injury here, they could have become what is called a cardiac cripple, unable to do anything except for the advent system is a very delicate, very finely balanced system that has a lot to do with the physiology and the timing. Now, what can happen in another aspect of this electrical system is some patients who, for example, might have valve stenosis, a tight valve. What's going to happen to an organ pushing against the tight valve? It might dilate. This valve might get big and thin-walled like an overblown balloon. Then what happens is the distance that the conduction has to go is further than normal. Not very far, but still further. And that can slow down and throw off the timing. This is another area, atrial dilatation, where the timing may be thrown off and the pacemaker may help. Let me go through now and show you the phases of the cardiac cycle, and then talk to you a little bit about how this is affected by all the timing and what's happening in the rest of the heart. The first phase, and I'm not going to get into specific pressures, but we're just going to talk about high and low pressure rather than numbers. We call the first phase the phase of relaxation. Nothing is pumping. It's a split second, literally a split second, where the atria on both sides and the ventricles on both sides. There's a law now that comes into place called Starling's law, sometimes called Frank-Starling's law, to give somebody else credit, which tells us that muscular contraction and its power is very dependent upon stretching. So if you have muscle that's at a normal length, just resting, it can contract with certain power. If you stretch it a little bit, it's like stretching a rubber band. It can contract with more power. And just like a rubber band, if you stretch it too much, it'll overstretch and lose power again. There's a place on that curve where you get the maximum power in Starling's law, and that's just what the ventricles do. Looking back again now, so this ventricle and this ventricle, like that extra little squirt of 30% of the blood to overstretch these muscles and allow a more powerful, efficient ejection of blood. That's Starling's law. allow a pause so the atria can contract before the ventricles do. In the next phase of ventricular filling and cardiac cycle, the valves are open at this point because blood is still flowing through. We have atrial contraction, which in this case is called atrial systole, but we usually don't talk about it. And then we are approaching the point where the valves are still open. These valves, the aortic and the pulmonic valves, are now opening because of contraction, and ventricular systole starts. Both sides, both together, and ventricles contract, and both these valves open to allow the blood to go out the pulmonic and aortic valves. This is the very beginning of the third stage. What happens to these valves? Well, there's clearly going to be back pressure here and here as the ventricle contracts, because this valve is open, the pulmonic, the aortic valve is open, but hemodynamics and pressure changes are going to close this valve and this valve, allowing no reflux, no regurgitation back into the atria. In patients who have regurgitation, for example, women I mentioned, and some men with mitral insufficiency, a prolapsed mitral valve, this little leaflet right here might flop back. Or do you remember the chordae tendini, the little tendons that held it? One of those might rupture and allow it to flop back. That would just decrease the efficiency of the whole ejection. So now you have the ejection phase. Blood is going out into the circulation, feeding the brain and the legs and the arms and all the organs. And blood is also going out here to the lungs for reoxygenation and for getting rid of waste materials. We'll talk more about that in the respiratory side of things. When we have completion of this cycle, it all starts again. The ventricles relax, blood comes back into the atria, and the whole cycle begins. And we have pressures changing constantly. High pressure in the two ventricles with low pressure in the atria. When the atria are contracting, the ventricles are relaxing, and they're trying to get the maximum aorta to fill and feed the myocardium. These are called the coronary arteries. Think about what's happening. At this point, the muscle is very strong muscle of the ventricle and some of the strong muscles on the right side of the heart as well are in tight constriction. They're pumping as hard as they can. The vessels that are trying to give them blood flow are being squeezed shut. The coronary vessels, which are feeding this very high place, systole, ventricular systole, cannot increase very much. It's already so efficient, so powerful, and so fast that there's no margin for it to increase. The entire reduction in the time is going to come out of diastole. The patient is going to lose the amount of time that the heart has to get its nourishment. No problem. Normally, if we have a normal heart, I can get my heart rate up to 160, 180 in an exercise treadmill with no problems at all. I won't feel any chest pain. If you took an EKG, there would not be any changes showing that the heart wasn't getting its normal amount of blood. However, suppose you had narrowing of a coronary vessel. Suppose one of those main vessels to the heart, which we've looked at, is narrowed now 70%. Walk around the grocery store, it's fine. Sit in a chair, it's fine. But cut down diastole, and it may not be fine. It may not be enough to feed the myocardium. We are not looking to find patients who have chest pain during this period of time. Those patients are going to come to us anyway. They're going to get up and walk too fast, climb lots of emergency equipment, defibrillators, medication. And we start the patient walking at a leisurely rate. And then every so many minutes, on a very set and fixed schedule, we increase the rate of speed and we monitor heart rate and blood pressure, both of which should go up in a normal person. Then eventually we get to the point where the patient may not be able to walk or run any faster. We can actually start elevating the treadmill, and we get different levels from 1 through 7 that are clearly defined as to speed and elevation and so on. Some of these patients who have serious disease will immediately start telling you, I have chest pain, disconcerting, they sweat, their blood pressure may get out of order, either too high or too low, and the test is immediately stopped. That's a positive stress test. It may take later, it may take a much longer time until the patient tells you they're having trouble, or they may not develop symptoms, but they might develop EKG changes, which I'll tell you about in a few minutes, that tell us they're having a problem, that the heart is not getting enough blood during diastole. But it's got even more sophisticated than that. It's gotten to be where we can really pick out patients who may have negative stress tests. In other words, nothing shows up on the treadmill, but we can see something in their heart. But what we do is something called a thallium stress test, which is actually now even being replaced by something more refined. Thallium is an isotope, a radioactive isotope that selectively is taken up by the myocardial muscle. Here's what we do. We can see this isotope using a very sophisticated Geiger counter, and it can give us an image in color of where the blood flow is to the heart. We can see bright yellow backwards. The patient now rests for 4 hours, and we do another scan. At this point, the blood will now go back to the places that may have been constricted during exercise, and we can see what was normal, because we have to compare before and after. Here's what a thallium stress test will look like in somebody who's got a problem. This is a patient who had no symptoms and went on the treadmill and got his thallium injection. This is the rest picture. Now, what this is a horizontal slice through the heart, taken by the Geiger counter. It is really only showing you the left ventricle. So if you can picture the cone shape of the left ventricle being sliced across, this is the ventricle itself where the blood is. This is the myocardium. It's very thick. We don't see the right side here. And the reason we don't see the right side is it takes up so much less thallium that we just don't get a good picture in comparison, because there's not that much muscle. Now, before exercise, it would look like this. In this case, of course, we've done it after the exercise when the patient's resting. But this is your resting thallium stress test showing good flow everywhere in the heart. The blue areas are the very edge of the heart, which doesn't have a big blood supply. That's entirely invisible in the blood itself here because it's all in the heart at this point. Look what happened to this patient during stress. This patient has a whole area of his heart which is not showing any blood flow at all. This is during that very short diastole, but the patient had no symptoms. This is a positive stress test. This patient is a very good candidate now to have an arteriogram. We can take dye and run it through the heart and see exactly the patients we can probably help the most. So that's the stress test, and that is a test that, while not perfect, any test we do is not necessarily perfect, gives a very good indication of the asymptomatic patient who might be very well helped by some kind of intervention before they get in trouble, before they knock off the heart muscle that may or may not kill them, and before they lose a lot of function. There's a lot of debate today whether this actually